Hello everyone. Today's topic is how to approach chest pain in ER. Are you all ready to listen this interesting and amazing session on chest pain? Okay. So, how to approach chest pain? So, we are going to see about the nursing perspective over here. Chest pain is a critical symptom requiring swift and accurate assessment, as we all know. Do you agree with me? Yes. Chest pain is something which we need to act on very swiftly, and we have to promptly assess whether it is a typical chest pain or atypical chest pain, or it is just as a gastric pain. So this session equips the nurses with the essential tools and knowledge to manage these time-sensitive cases and ensuring optimal patient outcome. So that is what we are going to learn in this session. So how to approach the chest pain, how we have to differentiate the mimicking chest pain from the gastric disorder with the cardiac chest pain, and how we have to promptly assess and treat the patient in a timely manner. That is what we are going to learn in this session. Okay, can we all proceed? Okay. So the session's objective is to recognize the life-threatening causes for the chest pain, how to do the systematic assessment in ER, and how to initiate early interventions at the earliest, and triage and escalation protocols. If you suspect any STEMI or NSTEMI, what is the escalation protocol over here, and how should we effectively communicate in such situation. These are all the training objectives of this session. Okay. So the critical nature of chest pain. I just want to quote a small thing over here, that is, not all chest pain is the heart attack, but every chest pain must be treated like it could be. Very, very important sentence. So not all the chest pain, all the patients who come to ER with the chest pain is not mimicking like a heart attack, but every chest pain we have to be treated it like a heart attack, though it is a heartburn or epigastric pain, or the pain could be due to abdominal infection or something like that. We have to treat them like a myocardial infection, because we should not neglect each and every single moment if the patient comes to ER with the complaints of chest pain. Okay, so chest pain is a leading cause of emergency room visit. We all know that, accounting for approximately 6 to 8% of all presentations. It can range from benign to actually life-threatening, demanding immediate attention. Time-sensitive conditions like acute myocardial infarction, aortic dissection, pulmonary embolism, tension pneumothorax, and esophageal rupture. These are all the conditions we have to act on very swiftly. What are all those cases? Acute MI, acute myocardial infection, especially your STEMI, ST elevation myocardial infection, then aortic dissection, which is a life-threatening condition, pulmonary embolism, again a life-threatening one, tension pneumothorax, if the patient comes with any road traffic accident with the tension pneumothorax, immediate ICD insertion plays a major role, or it creates a major impact in the faster outcome. Then esophageal rupture, which is also a life-threatening and should be acted on very early phase itself. So early recognition and rapid intervention of above conditions are paramount for improved successful outcome. Clear? So out of all the condition, what are the condition which is specific to time sensitive, apart from other neuro condition? We have acute myocardial infarction, aortic dissection, pulmonary embolism, tension pneumothorax, and esophageal rupture. Why I am telling you all this is because in all these conditions, patient will come to ER with the complaints of chest pain. Okay, so we have to act on very quickly. So this is the critical nature of chest pain. Once again, I repeat, not all chest pain is a heart attack, but every chest pain must be treated like a heart attack. Coming to the chest pain etiologies, which is nothing but the causes. The life-threatening conditions we all saw, no? So we have 5 major causes for the life-threatening condition. One is myocardial infarction. We are all very common with the term myocardial infection, which is commonly called as heart attack, which occurs due to blocked coronary artery. We all know that coronary artery is the one which supplies blood to the heart, When there is a block or any blockage in the coronary artery, what happens? Heart will not get adequate blood supply. In such situation, they may go into a condition which is called as myocardial infarction. Second one is the pulmonary embolism. You all know that embolism is a moving clot. Thrombus is a non-moving clot, whereas embolism is a moving clot. When the embolism goes and reaches the pulmonary side, it forms a life-threatening condition. Next is the aortic dissection. We all know that aorta is the major artery which is existing in our body. So when there is a condition called aortic dissection, which is a tear in the body's main artery, that will be a life-threatening condition and patient landed up with chest pain to ER. Tension pneumothorax in case of collapsed lung with increased intrapleural pressure. Esophageal rupture, which is the tear in the esophageal condition. So these are all the life-threatening causes which can landed up in chest pain and make the patient to landed up in ER. Clear with the big 5 causes? Okay. Coming to the other causes, we also have other condition which will cause chest pain for the patient. What are all those conditions? Your GERD. What do you mean by GERD? Gastroesophageal reflux disease. Then any musculoskeletal pain, costochondritis. You used to tell, no, people always used to say, I used to have this chest pain, when I take rest, it is getting subsided. Especially I have pain over the sideways, over the chest wall. We used to tell, so that is called as costochondritis. It also mimics like a chest pain. Then pneumonia or pleuritis. Then pericarditis, inflammation of the heart sac. Then panic attack or anxiety. What happens if some of our relatives maybe the death news of the relative, very close relatives, or sudden shocking news will make you to have this panic attack and will make you to become very anxious. That may also will cause you to have a chest pain. So that's all other common causes which will not be the exactly related to heart condition, but these are all other conditions which will give you the chest pain symptoms. Clear? This is the big 5 causes. What are all the big 5 causes? We have myocardial infarction, we have pulmonary embolism, aortic dissection, tension pneumothorax, and esophageal rupture. These big 5 conditions will cause you the chest pain, which we need to act on very swiftly. And other condition also may cause chest pain, that is your GERD, gastroesophageal reflux disease, musculoskeletal pain, pneumonia or pleuritis, pericarditis, and panic attack or anxiety. All these conditions will cause chest pain, but patient will not, they may not sure that they will having this the cardiac diseases or not. Okay, clear about the causes? Okay, let's move on. Recognizing key signs and symptoms. Already we saw the typical sign is chest pain. So apart from that, what all the other conditions associated with the chest pain will be occurring in the patient? So first and foremost is the pressure and radiating. What do you mean by pressure? Sometimes the pressure will be very sometimes the pressure is more high. Sometimes it will be associated with vomiting. So some patients, what will happen? The chest pain associated with vomiting, nausea, epigastric, stomach discomfort, and pain radiating to shoulder, lower jaw, upper jaw. These are all some of the signs and symptoms. How you have to triage the patient? The first critical step is the initial assessment, focusing on determining the patient's stability to guide immediate action and resource allocation. Okay, so what happens here? They have mentioned about the red flag signs, which is an unstable sign. So if the patient is critical, they will have all these signs and symptoms. One, altered mental status. What is that altered mental status? Patient will be not their GCS will be very poor. Either they feel drowsy, they will not related to orientated to time, place, and other things. They will be semi-conscious or subconscious or unconscious state also sometimes. Then hypotension, very significant feature. The systolic BP. What is the systolic BP? The above one is called systolic BP. So that will be less than 90. So patient will land up in hypotension. Then tachycardia or bradycardia. Most commonly tachycardia will be there, or some patients even they come to ER with bradycardia condition itself. Then RDS, respiratory distress, patient will have diaphoresis. What do you mean by diaphoresis? Excessive sweating. So patient will come to excessive sweatings in in the panic stage. These are all some of the signs and symptoms. Okay, how we have to assess? We have to do focused initial assessment. What is the focused initial assessment? Your ABCD approach, which we are very much familiar, right? So first we have to do the focused assessment using this ABCD approach. First what you have to do, A and B is nothing but your airway and breathing. You have to assess for compromise. Suppose when there is a airway pattern is not there, the patient is not breathing in a very good manner and the SpO2 start decreasing, what we have to do? You have to administer start oxygen if the saturation level is less than 94. For C, what you have to do? You have to check the heart rate, BP and perfusion status of the patient. For D, how you will be assessing? You have to assess the level of consciousness in order to rule out their disability. So you have to assess the level of consciousness and response to stimuli, external stimuli. Then E is your exposure. Conduct a full body checkup to assess any trauma or rashes or allergies are present in the body. So quickly you have to assess all these aspects, A, B, C, D, E. Okay, your airway breathing, your circulation pattern, your disability, that is the level of consciousness of the patient, and E is your exposure. After that, you have to do with the parallelly you have to do with the detailed pain assessment. So the typical symptom is the chest pain, which we have seen. In the chest pain, how the pain looks like. You have to do a thoroughly in-depth assessment of the pain should be done. How you will be doing it? You have to go with the PQRST mnemonic technique. So what is P here? Provocation. What makes it better or worse? So patient will be telling chest pain. So what makes it better? During rest the pain gets subside, or while walking the pain gets increased, or which are the position they feel like low chest pain, or it is not at all resolving. So the provoking factor you need to assess from the patient. Then Q. Q is the quality of the pain, whether it is a sharp pain or dull pain or some sort of pressure is hitting in the chest or some sort of burning. Definitely you need to ask all these questions. Okay. How the pain is, it is a sharp pain or it is a pricking pain or some pressure is putting on your chest or any burning sensation is happening in your chest. All the quality of the pain you have to ask. What is R? Radiation. Whether the pain is radiating to your jaws or arms and or back. You need to ask this question. Very, very important. The chest pain is there in chest alone or it is radiating to any jaw side or any over arms or back, like that you have to ask. And yes is your severity. So you have to ask the patient with the pain scale, how is your pain level? 0 from 0 to 10. Usually there will be severe pain ranging from 8 to 10. Some patients will also have moderate pain. So you all know the category of the pain scale, right? 0 is no pain and 10 is the worst pain. So 1 to 3 range is your mild pain and 4 to 6 is your moderate pain and 7 to 10 is your severe pain category. So with this we have to assess the severity of the pain. T is your timing. Whether the pain is all of a sudden or gradually increase and how long the patient is experiencing this pain, all those questions you have to ask. Clear with the PQRST? P is your provoking factor for the pain. Q is your quality of the pain. R is the radiation, where and all the pain is getting radiated. And S is your severity. And T is your timing of the pain. Clear with the focused initial assessment? Initially, you have to go with the ABCD approach to do the initial assessment. Then for pain alone, you will be doing an elaborative PQRST assessment. Clear? Okay. All the assessment findings should be meticulously documented in the case file for prompt treatment. Next is initial emergency department management. So you have prioritized the patient using ABC assessment. You have prioritized the airway, breathing and circulation. What is next? Immediately you have to connect the patient on cardiac monitor and start oxygen. Very, very important. You have to start connect the patient to the cardiac monitor and start oxygen. Take a 12-lead ECG. Though the patient is not complaining of any massive chest pain or nothing, when the patient tells you that he is having chest pain, definitely you have to do ABC assessment, cardiac monitoring and oxygen. You have to start and take 12-lead ECG. Very important, 12-lead ECG, not the 3-lead ECG. 12-lead ECG obtained within 10 minutes of arrival for rapid diagnosis. Let us secure the IV access. Always preferably to start 2 large bore IV cannulas in both the hands one for fluid rushing and another one for medication. If you want to thrombolize the patient, you will be keeping one separate IV line, right? So definitely you have to keep 2 large bore IV cannula, you have to secure it. Then you have to collect the blood sample for troponin I, D-dimer, CBC, and all other blood routines like renal function, arterial rate and coagulation profile have to be done for the patient. Then, so on the safer side, you have to give loading dose with aspirin. You have to administer the 300 milligram of tablet aspirin orally when there is no contraindication. So you have to consult with the doctor. Then for pain control, definitely pain will have severe pain. So you have to, for pain control, you have to give sublingual nitroglycerin or morphine can be given for the patient. An emergency situation, you have to plan for diagnostic imaging. Usually chest X-ray and if preferable CT scan, CT especially CT chest can be done in order to rule out aortic dissection or not. Clear? Or pulmonary embolism also. Clear? Clear with this? So you receive the patient, you will do ABC assessment and you will do cardiac monitoring immediately and you will start the patient on oxygen, take 12 lead ECG, 2 IV access and collect the blood sample for trop I, D-dimer, CBC and you will be giving the loading dose. So what is next? Red flags. So what is the red flag sign here over here? You have to, whenever you see this red flag sign, you have to immediately escalate to the consultant. What are all those red flags? One is your hypotension or shock. If you see the patient is in shock, low BP, feeling the weak thready pulse and the patient is having very poor perfusion, so definitely you have to escalate, patient is in shock case. Then there is altered mental status. How you will be assessing the GCS? So you have to talk to the patient, ask them to share their history. When the patient's conscious is poor or semi-conscious, subconscious, you have to report to the doctor very immediately. New confusion or syncope. What do you mean by syncope? Sudden loss of consciousness. Any syncope attack is there or patient is speaking in a confused manner, you need to escalate. In the 12-lead ECG, if you are finding any ST elevation or left bundle branch, you need to escalate. Then when there is a respiratory distress, you need to escalate. And unequal pulses or tracheal deviation, you need to escalate. Okay. And how you have to check the infarction by using ECG. So here you will be seeing the ST segment elevation. Usually this is the normal PQRS complex. What happened in ST elevation will be there. And some bundle branch block, your M-shaped waves will be seen. And sometimes T wave inversion will be there in case of ischemic attack. Okay. These are some of the significant changes you will be seeing in the myocardial infarction. Then targeted medical management. What is the medical management over here? So for MI, these are all the golden standards. Aspirin, antiplatelet, that is your loading dose. For pain, you have to give some nitrates sublingually. For in case of BP, patient is having hypertension, you have to start beta blockers and you have to start the patient on heparin or other anticoagulants in order to lyse the thrombus. And you have to plan along after discussion with the attendants, you have to plan for thrombolysis or urgent coronary intervention in case of staining. So in case of ST elevation MI, you need to treat the patient within a golden minute. Okay, you have to shift the patient to cath lab and plan for angio, and based on that the treatment can be modified. So this is for myocardial infarction. Okay, suppose if your diagnosis is pulmonary embolism, again you will be starting on O2 therapy, anticoagulant heparin you will be giving, and thrombolytics for massive unstable pulmonary embolism, and you have to plan for ICU admission if the patient is critical. And aortic dissection, very major and critical condition. What happens here? Immediate blood pressure control should be done. Patient will have high BP like anything. You have to give IV beta blockers immediately, and you have to consult with the surgical team for any surgery plan and avoid nitrates in order to worsen the dissection pain. In case of pneumothorax, what you have to do? You have to do needle decompression of chest tube insertion. You have to plan the patient for ICD insertion in order to prevent tension pneumothorax. Immediately you have to plan the ICD insertion. You have to start the patient on O2 therapy. Then esophageal rupture, again very important condition. So you will be keeping the patient on NPO, start IV fluid, start the antibiotic and plan for emergency surgery after the consultation with your surgical team. So these are all the 5 different big 5 causes and the each and every management for the big 5 causes. For MI, these are the management protocol. For pulmonary embolism, these are the things you need to do. For aortic dissection, this is the protocol, and for pneumothorax and for esophageal rupture. Clear? Okay. So comprehensive nursing management. So we have seen the medical management. What's the nursing management over here? So you have to do focused assessment. So by after triaging, you have to assess pain scale using PQRST. Again, I am repeating. P is the provoking factor, onset, what is the radiation thing, and the quality of the pain, and how long timing, how long the pain has been started, and you have to collect sample history for secondary diagnosis to evaluate the pain intensity, radiation, onset, and trigger. So focused assessment you need to do, and continuous monitoring. Put the patient on continuous cardiac monitor. You have to monitor them continuously and plan for timely intervention by orthotherapy and diagnostic test, CT, your MRA, your blood sample, all those stuff. And finally, you have to give some IV management. So definitely you have to secure IV access for in both the hands, preferably 2 large bore when you have to put. These are all the comprehensive nursing assessment. Clear? Okay. So key takeaway and next steps. What you have to do? You have to go with the systemic approach, early intervention, continuous monitoring, collaborative care, which we have already seen. So these are 4 aspects you need to keep in mind when the patient comes to ER with the complaint of chest pain. Okay. Next, quickly we'll see some of the case scenarios. Okay. So understanding the chest pain. So you are having understanding chest pain presentation. Patient will be having classic chest pain, atypical chest pain, and silent chest pain. These are all 3 different types of chest pain patient will be coming. Okay. Classic means severe pain that will be radiating to your left arm or shoulder or cheek, and often present with diaphoresis, which means excessive sweating associated with nausea also will be there. So this requires rapid intervention. Atypical is nothing but they will be having a mild pain, which is very dull in nature, which will not radiate to shoulder, or any tingling sensation will not be there, and often related to anxiety, but cardiac causes must be ruled out. That is atypical chest pain. Then silent chest pain, again very important thing we should not neglect over here. Patient will have subtle symptoms like fatigue, shortness of breath, or general tiredness, especially in case of diabetic patient. They have silent attack. They may not even have the chest pain, but they have vague symptoms. Shortness of breath, general tiredness, weakness, fatigue, and all will be there. So you have to suspect for MI and you have to act accordingly. Okay, so let's quickly brush through the case scenarios. A 58-year-old male coming to ER with a complaint of crushing chest pain for 30 minutes. So he has the history of hypertension and diabetes for quite some period of time. And vitals, these are the vitals. BP is 90-60, heart rate 108 with respiratory with saturation of 92%. And he is complaining of the pain score, severe pain, which is 9/10, radiated to left arm with diaphoresis and nausea. What will you suspect? Any clues? Yes, it is a classic STEMI. Classic ST elevation MI. What you will be doing? Same ST elevation you have to check, and you have to immediately call for ECG within 10 minutes, start oxygen, give loading dose with aspirin 300 mg, secure through IV access, notify doctor for post STEMI activation. So you have to prepare. The next step is you prepare cath lab team, and if ECG shows ST elevation, transfer the patient to cath lab or CGU for prompt management. So this is the approach you need to do. Clear? So once you confirm STEMI, take administer oxygen, give loading dose, notify to the doctor, secure the IV cannula, shift the patient to CGU or cath lab for coronary intervention. Let's see the second case study. 27 years old female with complaints of chest tightness for 2 hours. She has an history of recent emotional stress, no medical history. BP is 130/80, heart rate 88, and SpO2 99. And she is complaining of mild dull ache, not radiating pain, which is not even worse at rest. So other symptoms is tingling in sensation in fingers, and she is also having panic feeling. What will you suspect? Yes, it is exactly the symptoms of atypical chest pain. The primary concern is anxiety-related chest pain. You have to do again, you have to not neglect it. You have to take 12 lead ECG, reassurance, and make the environment very calm, monitor the patient continuously, and you are better on the safer side, do ECG and proper. If it is all normal, to give psychological support to the client, and focus on stress management technique for the patient, educate them, and discharge with the follow-up care and others. Okay, but so thinking that it is a atypical chest pain, we should not neglect. Definitely take ECG top by, confirm, and then only discharge the patient from ER. Okay. What is the third case study? 64-year-old female complains of mild shortness of breath and fatigue. She has a history of type 2 diabetes for quite some period of time and CKD, chronic kidney disease. And BP is 140/85, heart rate 94 and SpO2 95, and there is no significant chest pain she is complaining of, and other symptoms she is telling. She told light nausea, general malaise, and feeling off like that. So this is the vague symptom she is telling, and she is a known case of diabetic. So what will you suspect? Whether it is MI? Yes, definitely it is MI, silent MI. So it is a silent MI presentation. What you will do, you will have to perform ECG, take troponin, despite the absence of chest pain, and start cardiac monitoring and check CBG level, notify the doctor immediately. If ECG shows non-ST elevation changes, immediately call the medical help, and we can closely monitor the patient, and we can plan for further PCA interventions or other changes. Okay, so far we have seen a crispy session on how to approach chest pain. In that we have seen some of the major conditions which will which will give chest pain for the patient, especially your MI, your pulmonary embolism, your aortic rupture, your esophageal dissection, and your tension pneumothorax. These are all 5 typical conditions. Patient reports to ER with the complaints of chest pain. And apart from that, patient also will be complaining of chest pain in case of any gastric GERD condition or some other condition, any anxiety or panic attack. So to conclude, always any patient who comes to ER, all the chest pain, you have to consider that it is a MI pain, and you have to act fastly, and not all chest pains are related to cardiac condition. That we have to keep in mind, and we have to do a thorough prompt history, physical assessment, and secondary assessment using sample collection, and then you have to promptly notify to the doctor. Hope this session is useful to you all. I will catch you all in another interesting session. Bye.